Thank you for joining me today, Bill. It's nice to
Absolutely.
see your face because we've talked virtually for a little bit now through this. So
Yep.
let's start by can you just tell everybody a little bit about yourself, like what it is that you do exactly?
So I am an ED nurse. I've been in emergency medicine in different pathways for about 27 years. In 1993, I became a firefighter, paramedic, and have moved around and kind of jumped on since then. Um, I have been on some of the premier teams in the country and in the world um, in terms of emergency medicine. It's been a huge privilege, huge honor, and I've learned a tremendous amount. Part of my time through that is uh, learning about how to respond to this. I was actually, after 9/11, Bush put together response teams, and I was actually on the committee for my state that got together the emergency preparedness kits. This was back in about 2003. We set them up all over the state. The company that I work for was in charge of distributing those in case a mass incident happened. Um, what I saw is over a period of time, those things really kind of deteriorated in through H1N1, through swine flu. Supplies got used and never replenished. Um, so going back, kind of settled down into a less adrenaline zone in an ER. I'm not flying around. I'm not fighting fire anymore. Been a nurse for quite a number of years now, um, and love it. Enjoy it.
Great. Well, like I said, thank you so much for joining us and being willing to answer some questions. Obviously, you look like you're at work right now. Since you're at work, especially, what are things like there right now? I know there's a big difference between what different states and even different cities within different states are experiencing right now, but where you are, what is the situation like?
So I'm in one of the three states with the highest number of COVID-19 patients. I no longer work in the big, huge ERs. I work in a mid-sized hospital, 350 bed normally bed hospital. With our ER is about 50 beds, um, and so for us, what we're seeing, total patient volume is down. It's about in half, but our acuity is much higher. Um, our intubations per day have gone up about tenfold. Um, Most of those, whether they've been tested or not yet, well, they've all been tested now. Um, but whether we have the results back or not, through CT and X-ray, uh, we can uh, presumptively call them COVID-19 patients or SARS-2 patients.
Okay. I know there's been a lot of talk about the presumptive thing for people who are doubting a little bit more what's going on. Can you explain what presumptive means for a diagnosis?
So for us reporting to the state, for us diagnosing somebody with presumptive COVID-19 SARS-2, um, what we look at is the radiological evidence. So that is both done on X-ray and on CT. There is very definite signs. Um, this acts like pretty much nothing else. The rarity of this would be so high on a normal situation, and we're seeing it routinely now that in many cases it is actually easier to diagnose off of uh, the X-rays and CTs than it is even the testing that we have right now. Our testing, because we are a mid-sized hospital, we do not have our own testing yet. Ours is done through the state health department, which gets the test from the CDC, which aren't honestly the most accurate tests. We're still experiencing a pretty significant um, negative fail.
Okay.
So people have it. We know they have it because of radiological evidence, because of their presentation. Yet the nasal swabs are coming back negative. Hopefully, the antibody test will be online here momentarily. Hopefully, we can test it in-house because some of the manufacturers that are manufacturing tests have a much better accuracy rate than what the CDC does at this time.
Okay. So for those people that get a negative, but the radiological evidence shows that they have COVID-19, you're able to
Mm-hmm.
report that that is a positive case to the state?
Yeah, so we report it as a presumptive,
Mm-hmm.
and then what we do is there are labs that can draw and test for antibodies and are working towards testing for antibodies. We are sending those labs
Okay.
the blood work so that they can then test for those.
Okay. So you said that your tests, because of the hospital size, you don't test in-house, and that the type of the test that the CDC uses is less reliable than some others. So are there different different levels of tests, different kinds of tests that are being used in different places then that have different reliability?
Yeah, different kinds of tests,
Mm-hmm.
and with that then comes, so as with anything with the government, it's not necessarily the best and well put together. When you get it into the private sector, they have to be responsible for what their correct rate is.
Mm-hmm.
And so we tend to see much higher correct rates when it goes into the private sector versus when it goes through the government organizations.
Okay. Um, so we know from what you've said and from other examples that I've seen that false negatives are a thing. Are false
Mhm.
positives?
Not that we have seen.
Okay.
I I have seen no literature that would support that, and in my hospital and in friends' hospitals that coworkers that I work with, it would haven't seen any that were false positives.
Okay. Um, so about when do you think that you first started seeing cases that you think were potentially COVID-19 in your area?
So in February,
Okay.
we had uh, three fatalities here at my hospital that were bilateral interstitial pneumonia. At the time, it was before the evidence coming out of China showed that this is a huge, significant sign um, of COVID-19 SARS-2. Um, so um, that would be kind of my first. Could it have happened before that? Absolutely. Um, one of the seven hubs that fly direct from China is in my state. Could have it absolutely have gotten here earlier? Absolutely. And I have no doubt that it did.
Okay.
Um, so
Okay. So those few cases, those deaths that you would potentially attribute to coronavirus, um, was that something that was widely accepted at the hospital that you work in, or was that something that you
no,
just
it
thought
wasn't.
yourself?
It's actually at the time I didn't even think about it.
Okay.
It was just like the sucks what what happened. Um, Later going back, and it was probably a week to 2 weeks before we really started seeing good data come out about the bilateral interstitial pneumonia causing ARDS, DS, that was leading to these deaths and being one of the biggest ways, easiest ways to diagnose this disease. It was probably about a week to 2 weeks. So I went back and I looked at the CTs of these people, and I am not a radiologist. I can't diagnose somebody off of, but I look at a lot of them.
Mm-hmm.
To me, the examples that we were given were almost identical to what we had in the ER.
Around that time, were you said that you looked at the CT scans? Were there other people in the hospital that you work at that were keeping an eye out
No,
for
yeah,
this? Were people
no.
talking about coronavirus at the time, or?
So I'm on part of the team that would prepare us for that, and I was actively trying to get people engaged in this, and I was largely blown off, um, thinking that it wouldn't become anything. We've been through a couple of scares, H1N1, swine flu. that were honestly extremely deadly and were bad, but uh, they didn't pan out to be what a lot of people thought that they would be. So people kind of got lazy, lackadaisical, and didn't want to look at the evidence that was really coming out of China at that time.
Okay. It seems like the majority of hospitals of a decent size have had at least like one person like you that was a little bit of aware of what was going on and what might be coming, and they tried to do something and just kind of hit a dead end,
And
unfortunately.
it costs money
Mm-hmm.
in the end, um, and people don't, and people want to. It doesn't matter. I mean, after Katrina, I mean, we were all revved up. Hey, we're going to go into New Orleans, rebuild the levees, do all this kind of stuff, and it fizzled out. Right? A lot of the projects, a lot of the support for New Orleans fizzled out after less than a year. Um, it and people were still homeless. People in the Panhandle of Florida, their homes are destroyed. I mean, whole cities are destroyed, and very little is being done about it now.
Mm-hmm.
Um, people's attention span in the U.S. is pretty short.
It is.
And so if it's not sitting there staring them in the face, and I guess it is all around the world. People don't want to look at big, bad, scary things that are coming towards them.
Mm-hmm.
Um, you know, there's that fight or flight kind of response,
Mm-hmm.
and a lot of people flight.
Mm-hmm.
They want
They don't think so though.
to, look away. Yeah, I don't want to look at that. No, no. And what we really should be doing as people that are in charge of this kind of stuff is looking for it. And indeed, we do have teams around the U.S. that try to look forward and try to predict this stuff coming, and are often shamed if they don't turn out to be the big event
Mm-hmm.
or the Category 5 hurricane.
Mm-hmm.
Uh, and as a result of that, we don't have the level of preparedness that we probably should in this country.
Mm-hmm.
And it's been since 9/11 that FEMA has said, hey, at least since Hurricane Katrina, that FEMA has said, hey, you need at least 2 weeks of food in your house.
Mm-hmm.
And still, on average, in the U.S., people have 2 days.
Yep. Yes, you're
So,
right. Yeah. I think this is March 1st. I wrote an article that I had been meaning to do weeks before that about it might be a good time to revisit your emergency plan and your emergency preparedness in your home, not to panic, but just to think about it's important to be prepared because so few people aren't. I started looking up the data about like the percentage of American homes that have food and water for even a couple of days, and it's so few people are prepared for anything.
yeah,
So you don't have to go
yeah.
crazy. Just have some like extra pasta and stuff.
Having that 2 weeks a month, I think, I don't know what FEMA's their current recommendation is, but having that a little bit set back allows you not to panic and go buy toilet paper, which doesn't matter if you don't buy food,
Yes.
but um,
True.
it allows you not to panic. It gives you that safe zone of, hey, you know, I'm safe now. I can take care of my family. I can take care of
Mm-hmm.
my loved ones, and I don't have to panic.
Yes. People are starting to claim that deaths are being counted incorrectly. Like, if somebody has another condition and they die and there's a chance that they have coronavirus or they do, that will be classified as a coronavirus death. There's a lot of confusion online about that right now, and people trying to compare it to other things. So I'm wondering if you can shed some light on how the deaths are classified and if that's the same as deaths would be classified for like the flu or something like that. Is there anything different happening here or is it the same?
Not that I have seen, and not that I have seen in any of the reporting of this. So typically, the flu doesn't cause any deaths. The flu causes you to get pneumonia, and
Mm-hmm.
the pneumonia kills you. Or the flu causes your CHF to go off the charts, and then fluid builds up in your lungs, and you pass away that way.
Mm-hmm.
That is basically the same thing that happens with any virus. Even HIV. HIV doesn't kill you. It causes other conditions that does kill you. We still count those as deaths related to AIDS. We still count those as deaths related to the flu. That is the same way that I have seen that we have been reporting the deaths of the coronavirus, COVID-19. There hasn't been any change in that. And can it get into a slippery slope? Yeah, I guess it could, but it's not. So from a money standpoint, which would be the driving force of a hospital administration, you're not going to get paid more for a COVID-19 death than a heart attack. You know, as hospitals, we tend to try to push people out of the hospital as fast as we can. And we can go into the billing aspects of that and that kind of stuff, but that's all boring. But we can't do this. I mean, people are in the hospital for 18, 20 days at a time. One of my good friends is upstairs now. I have good friends that are admitted into ICUs and other hospitals that are infected with this. It's bad. People try to compare it to the flu, and you really just can't. Other than it's a virus. I guess you could compare it to the Spanish flu. You can some of the pandemic flus. I think that does a disservice not only to the Spanish flu and what happened with the Spanish flu and the education that we can get out of that, as well as H1N1 swine flu, the other more deadlier flu strains. I don't like it, but when people say it's just like the flu, here in the United States, we have about a 10% transmission rate. So about 10% of the populace every year get the flu. We have a mortality rate of about 0.11% on normal years. Some years that goes up a little bit. Some years it changes year to year. But overall, that's what we look at when we look at this. Right now, our mortality rate is still climbing. It'll likely climb through the end of May, and then it hopefully will start declining after that. From what the CDC, from what the WHO tells us, and the projections, the epidemiology studies that are being done right now. Hopefully that happens. If we can flatten this curve out and we can prolong it on, that might change, which is better for us in hospitals and will ultimately be better for the case fatality ratio. But we don't know now. It's an unknown. We really, really don't know. We don't know how many cases were here in the U.S. before we went into quarantine. We don't know how many people are really infected. We don't know we haven't had enough testing to really get a grip on where it is in the U.S. And to be honest, right now, I mean, we could test everybody in the U.S. and it really wouldn't change things from the way things are going right now. Because it's going to be what it's going to be at this point. Because we weren't able at the onset of this to get it really under control.
The New York Times and a couple of other outlets just now in the last day or so are reporting that the official COVID-19 death toll is probably very understated, that it could be twice that. What are your thoughts on a claim like that?
I would tend to agree with that because we have people, again, before we started mass testing people, or when the CDC took the tests away from us, that weren't being tested, that were still dying. We still know that they had bilateral interstitial pneumonia. We still know that they had those signs of what it is, but we had no way to test them. And we didn't start testing until late in the game. Again, we completely failed in January and in February and in March, for the most part, of testing, a lot of people. From what I'm hearing now, we're going to have that issue again, because a lot of the media, how we do the test, is made in China, and we can't get it. We're running out and we can't get it. So deaths are probably vastly unreported. The amount of people that have it are vastly underreported. There's been talk about, although I haven't seen anything definitive in any of the literature that says that they want to, and this will probably happen 6 months down the road, if not a little bit longer. Major universities will try to do studies to figure out, randomized studies throughout the populace, and figure out how many people, and extrapolate on that data on how many people actually contracted this. But I mean, we're months away from being able to even start that, let alone learn any answer from it. But I would 100% agree with them that this has been, that, both the number of deaths and the amount of people that have it has been vastly underreported. And that we're never really going to know that answer for years down the road.
Yeah. So from what you know of how this works, for people who have already died and died in January or February, and it wasn't even on anyone's radar that they might have coronavirus, is there a potential for them to be retroactively diagnosed? If they have CT scans, is that something that is possible?
They could. I have never seen that happen. Okay. But could they? Yes. Okay. The potential is there. I've just never seen anything like that happen before. Okay. Not to say that again, we have a lot more technology than we did 20 years ago, let alone back in 1918, the last real pandemic. So could that type of study be done? Yeah, it could. Relatively easy, especially with EMRs now. I've just never heard of it. And the talks that I have heard of studies that universities want to do are more randomized blood tests to see how many people, and then kind of extrapolate that data out. We'll never have a definitive answer at this point on how many deaths or on how many people actually had it, but we'll have a lot better estimate. And at the end of this, we'll come up with a case fatality ratio that is very, very, very close to what it was during this time. It's just going to take us a while to get that.
Yep, that is something that I've noticed, that I think people don't realize, that to get accurate data and numbers for these things, it doesn't happen while you're in the midst of it. It happens after.
Nope.
Like our flu season, it's all an estimate when we're in that flu season. They have to go, when it's over is when you can go back and look at the numbers and you confirm things, and then you calculate everything and you decide what actually happened. So the fact that people have been comparing a month into this, making comparisons about what they're seeing versus the flu 3 years ago, just makes no sense.
Absolutely. And even the flu this year. I mean, they're like, well, 18,000 people have died from the flu this year. And it's like, yeah, but we've only really started testing for this and even seen this for the last month in the US. How are you comparing something that's been going on for 6 months versus a month?
Yes, exactly.
And it doesn't make, logically, it just doesn't make a lot of sense.
It doesn't, but that was a common argument right at the beginning.
I hear that. I've had to leave a lot of groups on Facebook, on social media, because it drives me insane. Yep. And they're saying we have about a 50% adherence to stay-at-home orders right now. And honestly, that's not going to make a huge amount of difference in trying to slow this down at all. I mean, you really need 70-80%, the way China did it. If you believe their numbers, I don't, but if you believe their numbers, or even use their numbers just as a guideline, I mean, they were welding people inside their homes to keep them at home. We're not going to do that in the U.S. We never will. It's too big of a country. It's too much. We don't all live in the city. There's people like me that still live out in the sticks somewhere. And keeping us at home is just hard, right? We have different laws, different things that we have here. And when we only have a 50% adherence to that, and then we have all the essential workers on top of that that are still going to their jobs and still doing their things, you have a lot of people out and about that are spreading this, that don't know they have it and are spreading it, aren't intentionally spreading it, I don't think. I mean, you see the people going through, I forget where I saw the last video from, some store, anyways, it doesn't matter, with somebody licking their hand and going through and touching everything. You're always going to have crazy people out. It doesn't matter. It's, but for the most part, people don't want to knowingly spread it. They just don't know any better. They don't know they have it, or don't think that the rules should apply to them, and so they go do it anyways. The spring break kids, well, we're young and healthy, so nothing's going to happen to us.
Well, there was that thing where they messed up at the beginning of this, saying that young people won't get it. That was something that was repeated by people who have authority, so they shouldn't have repeated that, because it was obvious for anyone that followed it before it got here. It was obvious that you're not immune because you're young.
And like I said, I work in a medium-sized hospital, and I mean, we've intubated a lot of younger people, people that shouldn't be affected by this, but they are, and they're dying from it. And that's, it sucks. They're dying without their families. They're dying without anybody there. The fear that comes into people's eyes when they can't breathe, is horrid. It is one of the most frightening things that I've seen. I've seen gunshots, I've seen stabbings, I've seen all that kind of stuff. Like I said, I've been in this business for a long time. And the fear of somebody that can't breathe, and what that resembles in their face is something that I wish I could show to people, because of how horrifying and how much it affects you when you see that.
Yeah, I can't imagine what it's been like for you to have to experience that, with knowing what this is and knowing what people are experiencing it, and seeing that look in their eyes.
There are a lot of people out here that are doing everything they possibly can to help people, and that is a truly amazing thing to see. Yes, it's hard. It's hard when your friends die. One of my friends just died.
Sorry.
But at the same time, it's an absolute privilege to be able to take care of people.
Thank you for doing it. Yeah. One of my questions was going to be what is some of the most encouraging things that you're seeing right now, and I think I just got a little bit of it from you there. There are so many people kind of coming out of the woodwork, not just medical professionals, but people all over the place that are finding ways to support people right now, and it's beautiful.
Absolutely. I mean, we've had masks donated to us. We've had people bringing us food. We've had just a huge amount of support. Our parking lot the other night was filled with people giving us that support, and it's huge.
That is interesting that you brought up the full parking lot. I'm sure that you've seen on social media that people are being quite picky about the way that hospitals look right now, and it's rare to find a full parking lot. So you must not have had anyone there filming your parking lot trying to prove that it was empty at that moment.
And you know what? It was, but the reason why is because we won't let anybody into the hospital. People drop off people, so people are dying alone. People are dying without any of their family there. So all of our elective surgeries, all of our elective procedures, all of our doctors' offices that are in this hospital are closed We've had people pull up to the ER and try to take pictures of our waiting room, and our patient volume honestly is down. But our acuity is much, much, much higher. We're intubating at, like I said, 10 times the amount that we were before this. And we're purposely not putting anybody in the lobby, and they can't have family members. So our full lobbies, our 20, 30, 4 people in the lobby, 4-hour waits, 5-hour waits aren't there right now, thankfully. It's allowing us to see the people that need to be seen. But believe me, I mean, so we had 3 ICUs, 1 step down ICU here in this hospital before this. We now have 6 ICUs. And I'm actually standing in the next one that they made ready for our 7th ICU. To be able to accept that many people on vents, because we didn't have the space before this. And so they've turned, I mean, floors, we have multiple floors that are, all they are SARS-2 COVID-19 patients. Like I said, we have multiple ICUs. All they are SARS-2 COVID-19 patients. And they're all full. There's not a day that we're not holding people down in the ER waiting to get them up to those level of care. But thankfully, like I said, our total volume is down because we're not getting a lot of the things that we used to get, because people that don't absolutely need to be here aren't here. And that's a very good thing. Otherwise, we would be so overwhelmed and inundated. I honestly hate to think about it. I don't know what we would do if we had our level of patients that we're seeing the week before this to what we have now. I don't know how we would take care of them. I really don't.
I'm glad to hear that it worked out that way. That people listened, staying home, canceling elective procedures, that all of that helped. Yeah. That was a big concern, even for, like, I obviously don't work in a hospital, but right away, as I knew this was coming, that was a huge concern of mine, just wondering how is the normal stuff going to happen with this on top of it? How are hospitals not going to completely crumble under that weight? So it's good to hear from you that in your experience, all of that normal activity is down, and your hospital has been able to add ICUs and add the space needed. So that's all really good to hear.
Yeah, it's a good thing. I mean, our PACUs, our surgical units, they're now all ICUs. So it is good. It's given us the ability to effectively take care of people. So that is a very good thing.
Good. So what would you most want people to know about this situation and to understand, or something that they can do? What is the most important thing? If you had one thing that you could communicate to the world right now, what would you want to tell them?
The biggest one is stay at home. Give us a fighting chance. That this is, and then it goes into this really is real. It really is happening. Just because you don't know a neighbor that has had it, it's happening. It affects healthcare workers 20% more than it does others. So if you know people in healthcare, talk to them, because they know people that have been affected by this. They know people that have had this. But it's real, and we need all of the help and support we can get.
Speaking of...
And that biggest help and support is staying home.
Yes, definitely. Speaking of help and support, is there anything that you or your hospital need, that people watching, do you need donations of handmade masks? Is there anything that could directly support your work right now?
The biggest thing for us is going to be getting the Honeywells, the 3Ms back online, building the respirators. almost, and that's starting to happen. Um, and almost every nurse that I know that I work with have gone out. We've bought our own half-face respirators. We're providing all that equipment because we're trying to protect ourselves the best way we can. Um, I would probably tell people, please don't. It's one thing if you need them. If you don't need them, don't buy them. And I think a lot of the businesses have been really good at holding those back and getting them to healthcare facilities as they need them. Um, the biggest thing is going to be just that support. Um, there's been people doing tremendous things. Have a friend here, Amy, that has been donating huge amount of masks, and been able to fundraise and been able to find people to get them into the country, and has just been doing an amazing job. And that's huge. I don't, I'm here so much, I don't know how available that is, in terms of it being able to get those respirators and things in. I don't, other than finding them on Amazon on things, which Amazon has made everything so that you have to go through and prove that you're a healthcare worker or need them before you can get them, which is huge. So I don't know if there's other ways to do it or not, but contact those organizations that are trying to get them in. And I know, a lot of the car companies, they've been in building respirators, building those things. Those are huge. The face shields to help protect us is huge. That's amazing that they're stepping up and doing that for us. But to answer directly, I don't. While we desperately need supplies, I don't know really any, like, I don't know how to get those supplies to say yes. If you have a way to get them, that's awesome. Please, we need them. They're still wanting people. If you don't have a half-face respirator, they're still wanting people to reuse supplies that are supposed to be thrown away every time you come out of a room. Every time you come out of a room and you don't take that off and throw it away, you have a bigger chance of infecting yourself. Which is one of the reasons why our healthcare workers are so at risk right now, for getting this, is because we don't have it. I think I saw an article where one of the football team owners flew in, some amazing amount of N95 masks and passed them out to the local hospitals and stuff. That's awesome. If we can find ways to do that, that's awesome.
Yeah, I know as individuals it can be hard to do that because we're not all that wealthy. We don't have those connections, but people can petition to people like that, to your hometown hero that is the sports hero or whatever, or if you do, I live close to 3M's headquarters, things like that. If you have those connections, you can put pressure in that way on the people with the money and the industry who has the capabilities to try to help them either buy or manufacture the things that you guys need.
And there's been a huge, I can't tell you how many local shops have started, building the face masks, the full face masks and stuff like that around the area. I know we've gotten donations from companies that are really local to me, that are producing them, and that is huge. That's awesome. And I can't tell people how much we appreciate that, because it's quite literally saving our lives.
I think when this is all said and done, there needs to be a giant party with all these all these people, all these companies, everybody that made the connections and stepped out and made these things. It's in the midst of such a terrible thing, but it's such a positive, beautiful thing to witness at the same time.
It's like the day after 9/11, the whole entire country, it was just one country, and nothing mattered in the country, and we all came together, we all supported each other. And it would be awesome if we could kind of take that day or where we are right now and just continue that and support each other and be there for each other and be one country, one nation. And it, I hope we can get there. I truly do. I hope we can stay there, and continue that on where willing to help our neighbor, where we're willing to help, um, our country for the better, to make it better, to help people, to save lives.
Hmm.
That'd be awesome.
Yep, it's one of the hopeful things, the silver linings that might be on the other side of this is a huge increase in unity and uh, understanding that we can rely on each other, we can help each other. We don't need to wait for somebody to tell us to do it or to tell us how to do it, but
Yep,
we can do it ourselves. We can join together and provide what needs to be provided, and
absolutely.
hopefully on the other end of this, that's what we see, a big shift in values in that area.
That would be huge.
Hmm.
That would be awesome.
It's obvious that we need it right now, especially seeing the way that this took so long to get to where it needed to be. So much confusion, so much denial,
Hmm.
so many different groups working against each other. It couldn't be more obvious right now that that's what we need. So I hope that we see that.
Yep, me too.
Hmm.
Me too.
Well, I probably took up more of your time than I was supposed to,
Yeah, that's all good.
but thank you so much. Is there anything else that you want to say?
I think we covered it.
Okay.
Other than thank you for what you're doing, and um, letting people know what's going on. And thank you for being a voice out there. I really appreciate it.
Thank you so much for being willing to talk. Well, I'll let you get back to work.
Thank you. You have a good night.
You too. Keep doing all your good work. Thank you very
Thank you.
much.
Bye bye.
Bye.